said, and this was in the actual article, she said, "I believe Paul would still be alive today if he had received immediate trauma counselling. Paul and I were made to walk the length of the hospital with a nurse carrying our dead child, watching as other mothers went by with their pushchairs. Then we were ushered out without any proper help or advice. That's when I knew there was a major gap in the system, with nobody taking responsibility for bereavement support." This was her quote. "The current bereavement system in the NHS fails to offer any aftercare, particularly for grieving fathers." In February last year, baby George suffered from a fit and he was playing at a family home in Miskin near Cardiff. He was taken to hospital, but he died hours later. Doctors discovered that the fit was brought on by influenza and bronchial pneumonia, which had not been diagnosed. In the following days, the devastated couple started to plan George's funeral and talked of taking their other 2 children on holiday to Lapland. Mrs. Burke said, "One minute we were all a normal family, getting on with life. Next minute it was all over. Paul took the car for a drive and I didn't think any more of it." And these are the, on your right, that's a husband and the baby George, and that's Rianne Burke. So a traumatic event then. Every clinician, being whatever your role is within managing trauma, will always offer the best level of care to those that are physically injured. They'll always try their best. Whilst we pay attention to the physical elements of care, we have a mnemonic to lead us through the assessment, clearly careful attention should be paid to both the psychological and behavioural aspects of the care as well. Now, the characteristics common to a traumatic situation are these: an emotional reaction to a difficult event, the loss of the ability to function, feeling of being overwhelmed, the situation exceeds the coping levels that individuals actually have. Let's go back one. And I use an example here of a situation whereby I stopped at a road accident to assist. It was a young lad who had lost control of his vehicle and he'd hit a tree. The side of the car had been pushed in, so the middle bar of the car was sat next to his left shoulder, and he was still in the driver's seat, going in and out of consciousness. And I noticed that there was a colleague of mine from when I worked in the hospital who was indeed a nurse. What I noticed from her, though, is that she was running around not really knowing what to do, which is interesting because she was shocked as to what she'd seen. So in that situation, I thought it best to give her a job, and then it gives her some sense of direction and some purpose, and she won't lose that ability to function. So I just said, "Please, can you just control the traffic so we can start dealing with this young chap?" And it was because I think she was put outside of her normal coping situation. So characteristics of when you are exposed to a traumatic event include if you've had a previous exposure to trauma. So sometimes if you've been exposed to something that's been very traumatic and it's played on your mind, being exposed to something again may have a significant effect upon you. It does depend on your support systems you have, though. I'm a personal tutor to a number of student nurses, and there have been occasions where student nurses have actually experienced traumatic situations. So I've asked them, well, who do you have at home to talk to? Parents or any partners? And occasionally you get told there's no point talking to them because they don't understand. So it is about the support systems that you may have should you experience such an event. Clearly, there's issues around cultural responses and expectations as well. I do know that, for example, we have quite a large Irish population within the town I live, and they are quite a stoic sort of harder, perhaps, culture, where there are other cultures who respond in a very, very different way. We find Hispanics and Chinese become particularly emotional because it's their cultural background. Of course, it's the way you cope individually as well. So if you're not very good at coping in these situations, then it's clearly going to affect you. And of course, it's what defense mechanisms you have to control your own stress. Some people get exceptionally stressed and can't cope with it particularly well. Others seem to do very well. So what about then the sort of response you're expecting should somebody witness a traumatic event? Well, they can respond by a number of different ways, and from your perspective, particularly from a nursing side of things, or indeed or as doctor, it's anticipating what these responses might be. For example, you're stoically accepting. So if they were to witness something and they just, that's just the way things happen. Or they could demonstrate significant anger about what's happened, or indeed become violent, or become exceptionally tearful and also hysterical. And I've seen all of these different situations and responses, having worked within an emergency department. There's one, though, that comes to my mind, was a youngish chap who was late 20s, was probably twice the height of me, to be fair, and indeed twice the width. And the rugby team was short. So he asked his dad to play rugby. Well, his dad was an ex-rugby player, so his dad willingly said, I'd love to join the team. So they had their game of rugby. But unfortunately, his dad had a myocardial infarction, had a heart attack, and then went into cardiac arrest. And he didn't survive. So when they came to A&E, of course, the son blamed himself. So I took him into a room to break the bad news. I always sit nearer the door than furthest away from the door, because you never know how people are going to respond. So this guy stood up and he punched the wall. In fact, he put a hole through the wall, and I was quite pleased I was not on the receiving end. But I was near the door, so I could have made a run for it if need be. And it was an exceptional violent outburst. Now, I half anticipated something like that coming. So when you're assessing your patients initially, certainly within trauma, and not only from a nurse or doctor perspective, but indeed also from a paramedical perspective, that if we're going to move towards secondary assessment, there's a few things I think you need to consider. Well, when you're taking the history, for example, ask them about the recollection of the events. What do they remember about what's happened as the patient? But watch their reactions as well. Watch how, when they're describing the event, as to how they may respond. What you've got to think about, though, is think about the resources that you might need later on that might help to manage those effects. If they respond significantly to this trauma, what are you going to need to help you? Just like it may be if somebody has a fracture, what are you going to need to manage it? What about the physical signs? What can we look for physically? Well, when you're performing your head-to-toe examination, your secondary assessment, the signs might vary, because one of the problems with your physical assessment is that whilst we may see increased heart rate, increased respiratory rate, the patient may be nauseous or indeed sick, they could be sweaty, diaphoresis, they could be trembling or feeling apprehensive. These are all signs of things we see with patients when they become hypovolemic. So the response to the actual trauma psychologically could be difficult. In fact, I had a friend of mine who had all these symptoms and was always apprehensive, and actually at times found it very difficult to cope with things. In fact, he was assessed over a couple of years by various doctors and indeed psychiatrists, and he was diagnosed as being schizophrenic. However, he developed an abdominal problem, so he had an ultrasound scan, and they found a tumour on his adrenal gland. They call it a pheochromocytoma, but the tumour on his adrenal gland was producing so much adrenaline, that is why he was displaying all these what appeared to be psychological effects. Indeed, he's no longer schizophrenic because he had the tumour removed and all is well. So when we're looking for physical signs, just think about if there could be other causes too. But of course, there are some other key things to look for. Repeating the same story or the same questions, asking you what's happened, being quiet or indeed not being able to concentrate properly. There's the emotional side of things we need to assess as well, because that's all part of our holistic assessment. And we're looking for anger and disbelief. May not be wanting to be left alone, being fearful. So these are all things that you need to look for when you're performing your secondary assessment. What are the costs? What are the costs of somebody experiencing a traumatic event? Well, in the UK, there's been no study that I've found that actually has discussed or looked at prevalence of traumatic stress. We're going to assume it's about 1.5% of the population at any one time. And that's because it's drawn on data from both American and Australian studies. We're similar in culture, etc., and so we'll assume it's about 1.5%. Now we know that following a traumatic event, most people will recover within 6 to 12 months. That just depends. However, there is 1/3 of all of those experiencing that trauma who will remain symptomatic 3 years or more. That's quite significant. Of course, within the UK, there's another problem, and that's access to support. That's access to a clinical psychologist to seek professional help. Now, our GPs have great trouble trying to make referrals because there are so few of these people. 79% of GPs, in a study that was published within the guidelines for post-traumatic stress, experienced at least a 6-month wait before they could get their patient who'd suffered an traumatic event, to actually see a clinical psychologist. In fact, 22% of GPs had to wait 12 months. It doesn't match up, does it? It's the couple of days that George's father experienced. So in America, because we've got data on those costs, they say, and there's a website which is to do with post-traumatic stress, that 70% of adults will experience a traumatic event at least once in their lifetime. And that's quite significant. They actually say that 20% of them will actually develop post-traumatic stress disorder. Diagnosis for post-traumatic stress disorder, by the way, is relatively new as a diagnosis. I think this is alarming that the organisation actually stated that 8% of the American population have post-traumatic stress disorder at any given time. And I think that's a significant part of the population. The other thing, sorry ladies, but the other thing is that women are more likely, according to their data, to develop post-traumatic stress than men. However, in any event, an emotional trauma has really got three bits to it. It's got three components. An emotional trauma is it was totally unexpected. It wasn't planned, it happened, and we didn't expect it at all. The individual was actually totally unprepared for it as well. Wasn't going to expect it to happen. And the other thing, which I think is difficult, is that they couldn't do anything about stopping that incident. So, in terms of the response event, it's unpredictable. You can't measure it. And what is useful is just to think a little bit about the physiology of parts of the brain that are affected. So three main areas in the brain that are affected, certainly the cortex, where your higher thinking skills arise. You've got the middle part of the brain called the limbic system, where your emotions evolve, and indeed part of something called the amygdala. And the brain stem, and this is where all those basic transmissions are actually initiated from. So there's quite a lot of brain involved in dealing with this traumatic event. So what's the difference then? What's the difference between traumatic stress and post-traumatic stress disorder? Well, traumatic stress is defined as an event which goes beyond the normal range of experiences. So it's something you wouldn't normally expect. Now, we know most adults are resilient and may cope, and there may not be any psychological aftermath. They're things that you don't forget, but it doesn't sort of play on your everyday life. Whereas post-traumatic stress disorder is a term which is used to cluster symptoms together, whereby the experience could be experienced for a month or more after the event. So it plays and interferes with everyday life. And this is what I'm surprised with, because up until 1994, there wasn't a true diagnosis for post-traumatic stress disorder. It was the wars and the armed conflicts in things like Iraq, the Americans particularly, that actually did drive a diagnosis being recognised. And this is what they say. It's being exposed to a traumatic event in which a person experienced, witnessed, or was confronted with an event or events that involve death or threaten death or serious injury, or a threat to physical integrity of self or others. It's to do with the person's response involved in intense fear, helplessness or horror. So that was 1994, so quite recent as a diagnosis. However, there are other criteria that apply as well in terms of diagnosis. It has got to affect their daily life, it could be intrusive. The individual may avoid situations which may mimic or mirror what they experienced. And if they are to see something that's very similar to that event, it starts arousing a whole load of emotions again relating to that event. Diagnostically, it should cause some sort of occupational or social impairments. In other words, it does affect their general life day to day. So what's the likelihood then of developing post-traumatic stress and in terms of the incident? A number of years ago now, 30 years ago or so, there was an air crash in the middle of England. All died, and they diagnosed at the time that 40% of people that were involved were diagnosed as having post-traumatic stress disorder. However, another study looked at a sample of 188 road traffic collision victims, and only 10% of them were diagnosed as having post-traumatic stress disorder. So it's very much to do with the event itself, how significant that event was. Our other problem, of course, is that recognising it in children is really difficult. So again, that's just something to be borne in mind. So how do you recognise it? Well, symptoms are normally as follows. They may re-experience the event, and indeed they'll try and avoid anything that's similar to that event. They may have increased emotional response, or indeed emotional numbing to that event. May even appear depressed. They may turn to alcohol or drug misuse to help to cope with the event. They may be angry about it. Or they may have some unexplained physical symptoms. So it may be where they're attending and seeing a doctor or a nurse for things that may be totally unrelated, but they just may want to talk to you about that event. So it's not really clear about symptoms that actually do relate to a particular event, other than they may have flashbacks. Now, for children, because it's hard to diagnose, it's about asking the child, but take care not to rely upon the parental response, because you also have to be guarded about non-accidental injury. But do ask the parents, though, if the child's got any sleep problems. Are they irritable? Do they have difficulty concentrating at school in terms of school reports? So, in a traumatic event, then, there are 3 stages to the event. And perhaps the best analogy to use is the work by William Haddon. William Haddon looked at events that occurred and tried to account for why things happened. Because we all know that accidents aren't really, well, all accidents can be avoided. And so Haddon split up the events that occur, such as an accident, into 3 phases. A pre-trauma phase, and this is where the individual, both physically and mentally, can be assessed prior to the incident. So what state were they in? Then there's the trauma phase, so actually the event itself, and that'll be the effect of the incident. And then after the event. And it's after the event where they hadn't looked at the effects of an individual and indeed family. And this can be applied to all types of event, not just a traumatic event. But if we relate it to the events leading up to post-traumatic stress, then Watson and Shalev suggests that there's a number of things to think about. These are the characteristics that might make you more predisposed to post-traumatic stress disorder. That you're female, that you are about 40 to 60 years old, you don't cope very well, or you may be within your community an ethnic minority, may have had previous psychiatric problems or experienced prior trauma, may have previous anxiety, being an adult with children, and those of you that are parents, I do agree that sometimes children can be quite traumatic. Being a female with a partner, having an unstable family for support, or indeed being a child where they don't have a proper functional parental relationship and the relationship's dysfunctional. So they're the predisposing factors that might contribute to it to be aware of. But in terms of the event itself, then were they involved in the event or did they see it? I remember significantly driving past a car, should I say, which seemed to be stationary on the inside lane of a motorway, and then looking in my rear view mirror because I just passed a lorry, and then seeing the lorry hitting the car. And I won't forget that because it was quite shocking. I could see it was going to happen. Now, the other thing about the event is relating it to perhaps what other loved ones have experienced, or is it a threat to your life? Witnessing death, it's not nice. Or were you in a state of panic? Following the event, though, there are other things to think about as to what might lead to post-traumatic stress. Not having proper support or having marital problems with your spouse relationship. You may be in a position of losing your home or financial loss, especially if you've been involved in the trauma, or indeed reliving it. Being pestered by the media all the time, or being pestered by police for interviews. Relating it to other family members who have suffered a similar incident. Or relating it to the probability of it occurring to you. So they're all factors, characteristics that might actually increase your risk of developing post-traumatic stress. So what are the treatment options available? Well, we used to use this approach years ago of suggesting that we had a debrief. So straight after the event, certainly if it was something significant in my department at the time, I'd meet with staff and just quickly talk it through if there's anything anybody wants to ask. In fact, nobody recommends that now in the UK. It's suggested there's absolutely no benefit at all in having a debrief session straight after the event. And it's not really supported. What our national collaboration advice is in terms of evidence, organisation called NICE, what they do is they suggest a wait and watch approach. Let's see if the person will start developing signs and symptoms. So what happens is that if there's any sign of any symptoms developing, then they'll require follow-up. Now, hypnotherapy has been suggested as a treatment, but certainly medication-wise, which I'll come on to in a minute, that's not really recommended. What they do state in the best evidence is something called psychological first aid. And psychological first aid is being aware that the individual may have been affected and periodically throughout the weeks or months just offering the opportunity to talk about the problem. It's about removing the reminders of that situation that happened, if you can. It is about offering support and then reducing any effects. And sometimes that might also require education for staff. It's not been really tested as a method, though, so evidence-wise, we can't rely upon it. A common method used, certainly from our mental health perspective, is something called cognitive behavioural therapy. And this is like a reprogramming, if you wish, through extensive interviewing. It's more for long-term problems. What about drugs then? Well, drugs shouldn't be routinely offered. It's a quick fix for some doctors, just to give the patient some pills and to go away. All it does is masks the problem. If drug treatment is to be offered, it's to be offered by specialists. Now, the only drug that's licensed in the UK is a drug called paroxetine. Well, there are lots of others used, though. Might use propranolol, it's a beta blocker. You use that short term, but it's not a permanent fix. Use spiridone, that's used in psychiatry, and it may reduce flashbacks. But what they do advocate is not to use drugs of sedation. There's no evidence to support them. However, what about those caring for those that are injured? You. What we've got to think about, I think, is that certainly following a trauma, following, say, a motor vehicle accident, motor vehicle crash, is that we do need to think that care, psychological care, starts at that point. That the paramedics will start talking to the patient about what's happened, but also think about what they say. I don't know whether any of you have ever heard or seen or witnessed this, but when you're semi-conscious, lying on your back, possibly with a collar on, your hearing is very acute. Well, you can't see what's happening in the bed next to you or next to you because you're just looking upwards. And what if you hear a nurse saying, "It doesn't look very good, does it?" Okay, from the patient's perspective, they think it's them. So just take care also about what you say. So, what then about those that look after the injured? Well, it's recognised that some people are affected. I'm not going to say too much. But it is about improving self-awareness for you to look after each other a bit. Okay, now there's a study performed by Warren et al. Who actually looked at surgeons dealing with trauma. Now, there were 133 surgeons surveyed in this piece of work, looking at how they respond to stress, and certainly using different scales, such as a secondary traumatic stress scale, 22% of them did display signs of post-traumatic stress. So it does affect them as well. However, what I think is more remarkable is that 2/3 of all of them showed at least one symptom of traumatic stress. So it does affect everybody. So I think care's got to be taken as to how you recognise that. There's no correlation between the time that the event happened and the level of stress, because we all cope in different ways. Now, from a nursing perspective, the Royal College of Nursing actually says there's been no audit to date upon nurses within the United Kingdom and their risk of developing post-traumatic stress. That's concerning, isn't it, really? Now, many of the nurses offer the view, well, I'm okay, at least I'm not the victim, I'm not the casualty. Could have been worse. It's not me or my family that have been hurt, so why should I be complaining? And that's the attitude, perhaps, that a lot of nurses could take, but that event actually may affect them. And I don't think it's too dissimilar from how it affects the doctors, indeed the surgeons. So employers, I believe, shouldn't assume that because they're not showing any signs of not suffering, that they actually aren't suffering, because they may be. So I think employers should take heed. Now, the Royal College of Nursing suggest that any policies relating to looking at stress need to be reviewed every 6 months. And they suggest, within the UK, that employers must investigate or analyse any traumatic incident. We had there's one locally with ourselves in the UK. There was a minibus went into the back of a stationary lorry which didn't have the correct lighting. The minibus caught fire and 8 children died. The emergency team that was sent out from the hospital, which included many nurses and doctors, basically arrived to find 8 charred dead bodies. And that significantly affected them. In fact, there was one nurse, she was a sister, and she actually left 5 years after the event because she found it still playing on her mind and couldn't cope. She couldn't cope with the sights and the smells of the event. So it's important that employers do offer some form of risk assessment following a big traumatic event. They should have some policy for managing any critical incidents that occur. They should offer training and have clear referral pathways for those that suffer distress. They should also just think about post-traumatic stress disorder procedure and audit it on a regular basis to make sure it meets the needs of their staff. So there's some references that I've added to as well. I just wanted to say one other thing to you. Rhianne Burks has a charity now, and she's still raising funds for post-traumatic stress disorder for nurses and healthcare staff, in trying to recognise it to be able to treat it earlier than we currently do. Thanks very much.